Alright, well, hi again. As we agreed, the goal for this particular video is to help you in your final push in the review for the autonomic nervous system, knowing that some of you were not or did not start with me that early. So I figured the best way to keep you updated is that I will make those videos regularly for every chapter that we cover together. Now let's continue what I started with the first part of the slide of this video, which was the autonomic nervous system. We agreed that the role for the sympathetic division of the autonomic nervous system was to mobilize your body during activity, what we call fight or flight. Imagine yourself being chased by a bear, and what is it that you need? You need higher respiration or deeper respiration. You need higher heart rate, and your heart is pounding at that point. Sometimes you even have your hair sticking up and or goosebumps because you're very, very afraid or very, very anxious. Your pupils need to be dilated. All these things will be symptoms of what we call the sympathetic system activation. So you also need all the blood supply to go to your muscles and the brain, not necessarily the skin. You want to mobilize the sugar because you need that for energy. You don't necessarily need to digest anything at this point because it's the time now for fighting or the time for running away, and it's not the time for digestion or passing stool or passing urine at this point. So you will see that the blood flow is shunted to the skeletal muscles and to the heart. The bronchioles will dilate and the liver will release glucose because that's what you need for energy. Now if we compare now the two against each other, the sympathetic and the parasympathetic, you will see that there is significant difference between the two. The origin of the fibers for the sympathetic fibers is coming from what we call the thoracolumbar region on the spinal cord. That is why sometimes we refer to the sympathetic system as the thoracolumbar division of the autonomic nervous system. On the other hand, the parasympathetic system will be arising from the brainstem and from the sacral spinal cord. And that's why we call the parasympathetic the craniosacral division. Now in terms of the fibers, if you remember from part 1, we agreed that unlike the somatic motor system, where we only had one efferent fiber, in the autonomic nervous system we have two efferent fibers. One is before the ganglion and one after the ganglion. We called the one before the ganglion preganglionic fiber, and the one after we call that postganglionic fiber. Now for the sympathetic system, you will see that we have a very short preganglionic fiber in most of the cases. In most of the cases, you will see there are exceptions, but in most of the cases we have short preganglionic fibers and long postganglionic fibers. Quite the opposite in the parasympathetic system, where we have long preganglionic fibers and fairly short postganglionic fibers. Now the location of the ganglia, most of the cases for the sympathetic nervous system, can be close to the spinal cord in what we call the sympathetic chain or the sympathetic trunk. Versus for the parasympathetic system, you will find that sometimes inside the visceral effector organs, like inside the gonads, inside the urinary bladder. And that's very different than what we see over here in the sympathetic nervous system. It's not always that it's inside the effector organs. In some cases it's a little bit of a distance, and we will talk about that in details when we get to it. So this is a summary for what we were talking about. You will see here the sympathetic nervous system is arising from T1 to T12 and from L1 to L2 or L3, and that is coming from what we call the lateral horn. The preganglionic fibers will come, and in some cases they will synapse over here in the sympathetic trunk or the sympathetic chain. In some others, it will just pass without synapsing, and we will talk about that later. But at any event, all the sympathetic fibers are arising from what we call thoracolumbar division of your spinal cord, versus the parasympathetic system. We have some arising from the brain stem. 90% of the fibers will be carried, the parasympathetic fibers will be carried by this nerve here. We call that the vagus nerve, that is supplying the heart, the lungs, stomach, pancreas, liver, gallbladder, intestine, all that with a parasympathetic stimuli. And we will get into that in a short bit as well. And then the other component of the parasympathetic system is that we have the sacral division, and that will supply essentially your pelvic organs, the bladders, the genitals, the lower end of the large intestine, like the sigmoid colon and the rectum and the anus. So that is your parasympathetic and sympathetic plan, how the fibers are, and comparison between the two fibers. Let's now talk more about the parasympathetic division. And as we agreed, the parasympathetic division will fall into two categories. One of them will be the cranial outflow, and the other one is the sacral outflow. The cranial outflow will follow four cranial nerves that we covered together in AMP1. One is called the oculomotor nerve, that's number 3. Then the facial nerve, that's number 7. Glossopharyngeal nerve, that's number 9. And the vagus nerve, that's a very, very important nerve that covers about 90% of the parasympathetic fibers in your system. Now let's talk about each of those individually, and then we will talk about the sacral division or the sacral outflow, the fibers that are efferents from your sacral segments of your spinal cord. Let's start with the oculomotor nerve. As you remember, that's the nerve that moves most of the muscles of the extrinsic muscles of the eye. It's not only that, but it also moves the intrinsic muscles of the eye as well. What does it do? It would constrict your pupil, and it will also contract the ciliary muscle, causing close accommodation of the lens so you can read at a closer distance. We agreed before that whether the sympathetic fibers or the parasympathetic fibers, the efferents are composed of two fiber systems. One of them is called preganglionic fiber, and the other one is called postganglionic fibers, and therefore we have ganglia. The ganglion here for the oculomotor nerve will be called the ciliary ganglion, and it's inside the orbit. Now let's talk about the following nerve, which is facial nerve. If you remember, that nerve was covering a lot of motor activity of your face, but also the taste sensation from the anterior 2/3 of your tongue. Not only that, but it's also covering parasympathetic nerve fibers. The parasympathetic nerve fibers will give stimulation, parasympathetic stimulation, to the nasal glands, the lacrimal glands, and to the salivary glands. Now there are two divisions of the facial nerve parasympathetic fibers. Some of them will go to a ganglion that is behind the maxilla, and we call that ganglion pteropalatine ganglion. Pteropalatine ganglion. If you remember the pterygopalatine ganglion. If you remember the pterygoid plate, or the lateral and medial pterygoid plate, so the pterygopalatine ganglion is behind the maxilla. The other division of the autonomic nerve fibers that are carried by the facial nerve will be synapsing in another ganglion that is under the mandible. We'll call that submandibular ganglion. Now the pterygopalatine ganglion will give fibers that supply the nasal and the lacrimal glands, whereas the submandibular ganglion will give you fibers that will supply the salivary glands at the bottom of your mouth, so the sublingual and the submandibular glands. So that was facial nerve number 7, and facial nerve, which is cranial nerve number 7. That gets us to the next cranial nerve number 9, and we call that glossopharyngeal nerve. Now the glossopharyngeal nerve, we remember it was carrying a motor supply for some of the muscles in your neck, but that's not the only thing it does. It's also carrying some autonomic nervous system fibers to your parotid salivary gland. That's the one in front of your ear. Because the ganglion itself is very close to the ear and it's inside the middle ear, we will call that otic ganglion. The final nerve, but it's not the least, that is your vagus nerve, number 9. Remember that the vagus nerve is carrying about 90% of your sympathetic nervous fibers parasympathetic nerve fibers in your system. So it's a very, very important nerve, and it's essentially supplying everything: the heart, the lung, the visceral organs, the liver, the pancreas, you name it. The vagus nerve is starting, of course, in the medulla oblongata, for those of you who remember, and the ganglion will be either within the walls of the target organs or fairly close to them. Finally, we will get into the sacral division. The sacral division are arising from S2 to S4, and they will target the lower part of your intestine, will target your pelvic organs, urinary bladders, the lower end of the ureter, and your reproductive organs. Where would you find the ganglion? Will be, or the ganglia in this case, it would be within the walls of the target organs. Let's have a look again at this distribution. We agreed that here is cranial nerve number 3, that is your oculomotor nerve, is coming from your brainstem, and it is it's gonna synapse. The preganglionic fibers are gonna synapse with the postganglionic fibers at what we call the ciliary ganglion. It will supply the eye. It will give you motor fibers, autonomic motor fibers, to your pupil, and also to your ciliary muscle that is supporting your lens inside your eye. The next fiber was the next nerve was number 7, and the preganglionic fibers arising from the pons, or the junction between the pons and the medulla oblongata, and it will again synapse with the postganglionic fibers, and we agreed that there are 2 divisions. One of them we call the pterygopalatine ganglion, and the other one was the submandibular. The pterygopalatine will supply the nasal glands and the lacrimal glands, whereas the submandibular ganglion will supply those salivary glands at the bottom of your mouth, the submandibular and the sublingual glands. Now, if you go to cranial nerve number 9, as we said earlier, the preganglionic fibers coming from the medulla oblongata, they will relay, or they will synapse with the postganglionic fibers at what we call otic ganglion, and it will supply your parotid gland. Now, cranial nerve number 10, that is the most important, that's your vagus nerve. As you can see, it's supplying almost everything. And the ganglion is present very close to the organ where it's heading. So here's the gallbladder, here's the liver, or inside the organ, very, very close, or inside the organ. The lung, the heart, pancreas, stomach, and lots of the viscera in your abdomen. Except the lower portion will be covered with the sacral division, which is also supplying the gonads and the urinary bladder and the lower end of the ureters. Now let's talk about the sympathetic nervous system, or the thoracolumbar division. So we agreed that the preganglionic neurons, the soma, the body of the preganglionic neurons, is or are in the spinal cord segments from T1 to L2. The collection or the accumulation of those sympathetic neurons will produce what we call the lateral horns of the spinal cord, the lateral horns of the spinal cord. Now, the preganglionic fibers will pass through what we call the white rami communicantis and will enter the sympathetic trunk And here we have three options, as we will see. Once it enters the sympathetic trunk, or the paravertebral ganglion, or the sympathetic chain, all these names are the same thing for the ganglia or the chain of ganglia that are present lateral to your vertebral column. Now we have three options. Either they will synapse immediately, or they will ascend up or descend down within the sympathetic chain, and then they will synapse, or they will pass through the sympathetic chain and they will not synapse. And let's discuss all these three options. Let's first have a general idea about the sympathetic nerve fibers. As we agreed, they are arising from T1 to L2, and they are coming, of course, from the lateral horn of those spinal segments within your spinal cord. The preganglionic fibers, they will pass and then they will enter the sympathetic trunk or the sympathetic chain, and then it's either that they synapse immediately, or they will ascend up or descend down. And from that point, some of them do in fact, as you see here in the picture, do in fact synapse, whereas others pass without synapsing. And we will talk about each of those separately. Now, the ones that would synapse, it would go up because we have area here within the cervical, within the thoracic chain that is within the cervical region. And that's the only way, really, that we get sympathetic nerve supply coming from the cervical region, because the cervical region itself within the spinal cord does not send any efferent fibers. So we would send it through the thoracic fibers, those ones or the lumbar, and then it would climb up to form an area here in the cervical region. And that's very important, because nerve fibers that are coming then from your cervical spinal cord those fibers, the sympathetic fibers, will hitch a ride on them, and they go on the same path. They don't just walk by themselves, except when they are surrounding blood vessels like the cardiac and pulmonary arteries, and they will make what we call cardiac and pulmonary plexus. So this is another way for the nerves to follow and reach the organs. And that is especially true for the heart and the lung. However, if we want to reach for the skin or the face or the salivary glands, we would need to piggyback on other nerves that are supplying the skin, other somatic nerves that are supplying the skin, supplying the face, supplying the sweat glands, as we will see later on. Now, there are those fibers that will pass without any relay, and they will form to us two nerves, and we will see the picture of those nerves in the following slides. The first nerve is called greater splanchnic nerves. Imagine all those fibers will unite together in front of your vertebral column to make what we call greater splanchnic nerve. They also unite to make what we call lesser splanchnic nerve. Now, this was the preganglionic fiber. As you see, the fibers just went through without synapsing in the sympathetic chain. The greater and the lesser splanchnic nerve will go to your abdominal cavity, and then they will synapse. They will synapse in places like the celiac ganglion, or the superior or the inferior, or the superior mesenteric ganglion. The inferior mesenteric ganglion will be coming from your lumbar splanchnic nerve. Here is the lumbar splanchnic nerve here, and that will synapse at the inferior mesenteric ganglion. At any event, the postganglionic fibers then that are arising from all those ganglia that are not the ganglia that you see here on the sympathetic chain, they just passed through, but they did not synapse. And always remember, in the sympathetic and the parasympathetic, you need both preganglionic fibers and postganglionic fibers. So the preganglionic are going through, not synapsing, until they reach the ganglia here, like celiac, superior mesenteric in this case, and inferior mesenteric here, and they will supply the organs, the liver, so they cause mobilization of sugar, for example, the stomach, they cause relaxation, and they close the sphincters, spleen, kidneys. Adrenal gland is receiving preganglionic fibers. We agreed that the adrenal gland in the lecture, we agreed to this, that the adrenal gland itself is a modified post-accumulation of postganglionic fibers. And it does secrete adrenaline and noradrenaline straight out from it. Finally, we have those sacral splanchnic nerves. They will be coming from the sacral division, not of the spinal cord, but of what we call the splanchnic, from what we call the sympathetic chain. It will form to us sacral splanchnic nerve, and that will supply the reproductive organs and will supply your urinary bladder with sympathetic nerve fibers. This is the picture I told you earlier, how some of the fibers from the sympathetic trunk will go through without any synapsing here at the sympathetic ganglion, and they will form together this nerve here, which we call thoracic splanchnic nerves. We have greater and lesser thoracic splanchnic nerve, and then we have the lumbar, and then we have also the sacral. We can also see here from here the origin of your spinal nerves, and if you remember, we have the ventral and the dorsal roots of your spinal nerves, and they will unite in the trunk, and then they will split into ventral and dorsal rami, or anterior and posterior rami. Now the anterior ramus will give you a communicating fiber here. We call it white ramus communicans. White ramus communicans, or white ramus communicantis. And this white ramus will carry the efferent fibers that are going to the sympathetic ganglion or the sympathetic chain. Now out of it will come, if it synapses here, then it will give us postganglionic fibers. But you need to remember one thing, that the postganglionic fibers are unmyelinated, and the unmyelination here causing the fibers to be grayish, not white, because it doesn't have any myelin, and we will call those gray ramus communicantis. Gray rami or gray ramus communicantis. Now this is very important in terms of injuring or damaging those. Remember that the postganglionic fibers can be fairly long in the sympathetic nervous system, and any injury to the postganglionic fibers will result in permanent damage, because those fibers, as we said in the lecture, are not capable of healing themselves. They don't have the Schwann cells that can repair the damage. So a lot of people, when they go to a surgery, sometimes they end up with losing the control of their bladder, for example, or losing their male reproductive functions, and that's because of injuries to the postganglionic fibers. And let's all agree that the postganglionic fibers are unmyelinated. So as we agreed here, when the preganglionic fibers enter the sympathetic trunk, there are three options. One of them, it will synapse immediately at the same level, and the other one is will either ascend or descend in the sympathetic trunk, and it will synapse at another level. And the third option, it will pass through and will emerge still as preganglionic fiber, and then it will synapse. So here's the first option. The fibers are coming from your lateral horn of your spinal cord, and they will go through the ventral root, the trunk, the anterior ramus, and then they will give you a fiber here with the white ramus communicantis, and then that will synapse with the postganglionic fiber, but it will synapse here at the same level of the spinal cord where the nerve emerged. So this is scenario number one. Scenario number two, it would again go out. Here's the white ramus communicans, but it's not going to emerge out as the gray ramus communicans here. Instead, it will continue going up or down. Then it will synapse and then it will go as the gray ramus communicants here to the effector. Now the third option will be that it will go again here from the lateral horn of your spinal cord, thoracic and lumbar spinal cord, and then will go in, will pass through your sympathetic ganglion without synapsing. Then it will reach a further, or what we call collateral ganglion, such as celiac, mesenteric ganglia, and then it will synapse with your postganglionic fiber. If it does synapse at the chain, the thoracic chain, then it or the sympathetic chain, then these fibers will innervate immediate synapsing. Then it would that would stimulate the sweat glands, erector pili. These are the little muscles that are attached to your hair follicles, and their action is more abundant in your cat. For example, if you scare a cat, you see all the hair sticking out, whereas in us it just causes our skin to get those goosebumps. The vascular smooth muscles will be also innervated by those fibers. Now to the head, they will emerge from T1 to T4, and then they will go up to the superior cervical ganglion, where they will synapse there. That also will innervate the skin and the blood vessels of the head. It will stimulate the dilator muscles of the iris, and it will inhibit the nasal secretion. It would will activate what we call mucus secretion, which is much less than the watery secretion we see with the parasympathetic stimulation. The ones in the thorax, they are emerging from T1 to T6, and they will synapse at the cervical trunk ganglion. The postganglionic fibers, they will go from they will enter the spinal nerves C4 to C8, and they will stimulate the heart via what we call the cardiac plexus, the thyroid gland, the lungs, the esophagus. All of those guys will be stimulated by those sympathetic fibers, thoracic sympathetic fibers. If they would synapse at the collateral ganglion, we agreed that they will synapse at what we called celiac and superior inferior mesenteric ganglia, and then you are supplying essentially the organs in your abdomen, such as the liver, your small intestine. If we go to the pathway in the abdomen, these are coming from T5 to L2. They will synapse in the celiac and the superior mesenteric ganglion, as I just said, and it will supply the liver, spleen, and the kidneys, whereas the lower one in the pelvis, we will have from T10 to L2. They will travel down, and then they will synapse at the sacral splanchnic. They will go as the sacral splanchnic nerves, and then they will synapse in the inferior mesenteric and the hypogastric ganglia. Those will supply sympathetic stimulation to your large intestine, urinary bladders, and the reproductive organs, essentially your pelvic organs. We also agreed that the adrenal medulla is sort of a modified collection of postganglionic fibers. So when it receives preganglionic fibers, then it will secrete to you noradrenaline and adrenaline. We need to understand that there is a reflex arc, just like the one we saw at the somatic nervous system. You remember the knee-jerk effect, or when you step on something and you have to withdraw your foot away. We have the same thing with the parasympathetic system. However, we also agreed that the parasympathetic system is only motor. So it's using the sensory the sensory nerves from the somatic nerve system for its input or for its afferent signals. Now, if we look here at the picture, you will understand and appreciate what is that visceral reflex. It will utilize the sensory receptors that are in the viscera, and then it will go through the dorsal root ganglion, the same pathway we know. However, it's not going to ascend or descend like we know, or ascend, there is no descending here. It's not going to ascend as we know from the somatic nervous system. However, it will just cross over and will synapse with our the body of our lateral horn sympathetic nerve fiber, and that causes a reflex. When you feel something in your stomach, or when you feel something in the intestine, or when you feel something in your reproductive organs, that will cause immediate activation of the sympathetic or the parasympathetic, but in this case here we are illustrating the sympathetic nerve fibers. And as you can see here, here is again the afferent signal coming in. It will synapse with the sympathetic nerve fiber, and it will go out as the efferent signal to the visceral organ. That is very important what we saw here, because as the as the autonomic nervous system is using the somatic or sensory fibers, then it's very easy to be confused where the signal is coming from. So the fibers that are supplying, for example, our heart will be carried by sort of the same nerve that is covering sensory information from our left shoulder and our left arm. And the same thing with the gallbladder. The information that's carried by the gallbladder is carried pretty much by the same nerve, or the nerve division, spinal nerve, that is carrying information from your right shoulder. Because our brain is used to receiving information from our skin, not necessarily our viscera, it's easy for our brain to mistake where the signal is coming from, and that's what we call referred pain. And the referred pain happens in many areas. The most famous one is the heart. When someone gets a heart attack or a slight angina pectoris, then the pain is felt in the pectoral region here of the left pectoral region, and on the inner side of the left arm all the way down to the pinky. When someone has a gallbladder problem, whether it's stones or infection, then the pain is felt often at the shoulder, and so on. There are many examples of what we call referred pain. The neurotransmitters that are in the autonomic nervous system, unlike our somatic nervous system or somatic motor system, where we only had acetylcholine stimulating our muscle, here we have more than one neurotransmitter. For all the parasympathetic nerve fibers, whether they are preganglionic fibers or postganglionic fibers, they will have acetylcholine as the neurotransmitter. For the sympathetic fibers, the preganglionic fibers will have acetylcholine, whereas the postganglionic fibers will secrete either adrenaline or adrenaline, or in rare occasions we will have acetylcholine. And the rare occasions are those fibers that give to the sweat glands and some blood vessels in the skeletal muscles, and those will be secreting acetylcholine instead of adrenaline or adrenaline. And this is a picture, just tells you what I already said. All the preganglionic fibers, and if we agree that the adrenal gland is receiving also preganglionic fibers, we will have acetylcholine. In the post-ganglionic fibers, only the parasympathetic will have acetylcholine. Most of our sympathetic post-ganglionic fibers will secrete noradrenaline and adrenaline, except very few that are going to the sweat glands and some vascular muscle fibers that will be secreting instead acetylcholine. Acetylcholine receptors, we'll call that or those cholinergic receptors, and the other one will be called adrenergic receptors. These are for adrenaline and noradrenaline. Now let's start with the cholinergic receptors. The cholinergic receptors, we will have two types. One of them is called nicotinic receptor, and the other one is muscarinic receptor. They are named after two drugs that can affect those receptors and can bind to those receptors. One is called nicotine, that's found in the cigarettes, we all know that one. And the other one is called muscarine, which is a toxin found in certain types of mushrooms. The nicotinic receptors found at the motor end plates of the skeletal muscles, so essentially the somatic motor end plate, and all the ganglionic fiber, all the ganglions, or it's secreted by all the preganglionic fibers, so we will find them in all the ganglions, both sympathetic and parasympathetic. And because the adrenal medulla is considered a ganglion itself, so we will find that secreted by the preganglionic fibers that are supplying the adrenal medulla. The nicotinic receptors, the activation of the nicotinic receptors, the acetylcholine nicotinic receptors, is always stimulatory. Now the muscarinic receptors, these are still cholinergic receptors, but they can be stimulated by what we call muscarine, which is a toxin from a mushroom. Where do we find them? We find them in all the parasympathetic postganglionic fibers, in all the postganglionic fibers that are whether sympathetic or parasympathetic, as long as they have acetylcholine in them, then you will find those muscarinic receptors. The effect of acetylcholine on the muscarinic receptors, unlike the nicotinic receptors, can be inhibitory or excitatory, and that depends on the type of the receptors and the target organ. And so here's a summary of what I just told you about the two types of the acetylcholine or the cholinergic receptors, nicotinic and the muscarinic receptors. Let's go cover the other side, which is called adrenergic receptors. Adrenergic receptors, these are the type of receptors that will respond to adrenaline and noradrenaline. We will have alpha receptors, subtypes alpha 1 and alpha 2. We have beta receptors, beta 1, beta 2, and the beta 3 is in the fat cells. The effect of the noradrenaline will depend which subclass is dominating at the target organ. Beta 1, for example, causes acceleration of the heartbeat. Beta 2 is in the lungs and the bronchioles, and it will cause dilation if it's stimulated of the blood vessels. Beta 3 is in the adipose tissue, and that stimulates the lipolysis, the breakup of fat, so you can use that for energy. Alpha 1 and alpha 2, they are very important for the blood vessels. Alpha 1 especially, because alpha 1 receptor, adrenergic receptor, that causes vasoconstriction in everywhere except in the heart. You wouldn't find that in the heart. Constricts the blood vessels, it constricts the visceral organ sphincters, so you don't pass urine, you don't pass stool. Also, these are the receptors, the alpha 1, they are present in the pupils of the eye. That is the one that dilates the pupil of the eye. Alpha 2, you will find those at the membrane of adrenergic axon terminals in the pancreas and also in the blood platelets. It's very important to understand all these different types of receptors, because then we can utilize this information to design a drug that will only act on those particular receptors. Let's have an example. If someone has arrhythmia and his heart is pounding very fast and you want to slow it down, you would use beta 1 adrenergic blocker. So you would stop the activation of the beta 1 receptors, therefore the heart would slow down. If you want someone to breathe better and someone is in asthmatic attack, then you give beta 2 mimics, and that will cause dilatation of your bronchioles, and therefore the person will sustain that asthmatic attack. If someone has nasal congestion or allergy and you want to cause vasoconstriction of the blood vessels, so you give spray that is alpha 1 stimulant, like Sudafed, for example. So the effect of drugs, of course, will depend on what receptor are we acting on and what is the action. And here are some examples of the parasympathetic system. Atropine, for example, is anticholinergic. It would block the muscarinic receptors, and that would reduce the salivation because you don't want to choke when you go to surgery. And it will also dilate your pupil, since now we blocked the parasympathetic stimulation to our pupil, to our iris. Newstigmine is another drug that will inhibit the breakdown of your acetylcholine. It inhibits the acetylcholinesterase, and it can be used to treat myasthenia gravis. Other drugs, as I mentioned earlier, you can stimulate alpha-adrenergic receptors in nasal decongestants. You can use beta-2 drugs to activate beta-2 receptors, and that will allow the bronchioles to dilate in asthmatic patients. We call those, they're not beta-2 blockers, this is a mistake, it's beta-2 mimics. They mimic the action of beta-2 activators or adrenaline on the beta-2 receptors. Now we also need to understand that both branches of the autonomic nervous system, they collide or they communicate with each other, not necessarily collide. So in most cases they're opposing each other, like one will cause constriction of your pupil, the other one will cause dilatation of the pupil. But sometimes they work together, like on the salivary glands. One will cause, that's the parasympathetic, will cause the watery saliva, and the other one, which is the sympathetic, will cause the mucus saliva, the mucoid saliva. And so both together, you need those two secretions in order to have the optimal secretion. But also it can be that one opens the gate for the other one, like in the sexual reproduction. We have the parasympathetic will cause erection, and the sympathetic will cause later on ejaculation. So one opens the door to the other, and so that can be one kind of interaction between the autonomic nervous system divisions, the sympathetic and the parasympathetic system. We get to talk about the sympathetic tone, and essentially tone means consistent, something, if you remember, the muscle tone from AMP1. So we have consistent semi-activation, and you will see that in certain areas. The sympathetic tone, for example, keeps the blood vessels at semi-constricted state, because if they dilate all the way, then they will absorb all the blood, and the blood is not going to return to your brain. So it's in partial constriction, and because they are under what we call sympathetic tone. But we can also have parasympathetic tone, which is, for example, supplying the heart. The heart is under constant inhibition by the vagus nerve. Why is that? Because if it was left without the vagus nerve, then the rate will be excessive. The heart rate will be excessive, and we don't want that. And if you ever block the parasympathetic response, of course it will increase the heart rate, and it would block the fecal and the urinary retention. So for example, when you have atropine and when you come out from the surgery, quite often you suffer from being unable to pass urine, or you have constipation. We talked about the cooperative effect, and that can be found, for example, in the external genitalia, where the parasympathetic fibers will cause one thing, and the sympathetic fibers will cause ejaculation of semen in the males and the contraction of the female vagina. And we will talk about that when we get to the reproductive organs. There are certain other rules for the sympathetic division. It can give you a thermo-regulatory response to heat. For example, if you feel cold, it will, if you are in a cold environment, then it will vasoconstrict your blood vessels. The sympathetic fibers also, or the sympathetic stimulation, can stimulate what we call renin stimulation from the kidney, and that will cleave something called angiotensinogen 1, which will be converted later into angiotensinogen 2. And these are all mechanisms. We will learn about them later on when we cover the urinary system. Metabolic effect that is unique to the sympathetic system. It increases the metabolic rate of the cells, raises the blood glucose level, and mobilizes fat by activation of beta-3 receptors. What we notice is that the parasympathetic division, the stimulation is short-lived and highly localized, and the sympathetic division is long-lasting and it's body-wide. Why is that? Because the division of the preganglionic fibers are tremendous with the sympathetic division. So it ends up that a stimulation of one preganglionic fiber neuron will stimulate many postganglionic fibers. So you can't localize the effects. That's why when your heart is pounding, you will also see that you're breathing deeper. You will see that your eyes are dilated. But that's not the only reason. One other reason is the fact that the sympathetic system will work through the secretion of the adrenal gland. And the adrenal gland secretion, the adrenaline and noradrenaline, will get into the blood, and therefore it's widespread. It will go essentially everywhere, and it will stimulate those organs. Well, that explains why it's not localized. That explains why it's body-wide. But why is it long-lasting? If you remember from the parasympathetic system, our neurotransmitter there was acetylcholine. Acetylcholine is removed immediately, either by uptake or by an enzyme called acetylcholinesterase. Now, the sympathetic division, on the other hand, it's very hard to pick the adrenaline and noradrenaline. Add to this difficulty if adrenaline and noradrenaline find their way to the blood. Then it lasts very long, because the only way to clear your system from adrenaline and noradrenaline is by the liver. So it takes you longer time when you are afraid, when you are angry, to calm down, because the liver has to get rid of all that extra adrenaline and noradrenaline in the blood, which is not very easy to do. It takes some time. The control of the autonomic nervous system, we have hypothalamic control, but we also have subconscious control, like you're watching a movie or you're thinking of something and then you got afraid or you got relaxed. All of these things are from the limbic system, and they can activate or inhibit the sympathetic or the parasympathetic system depending on the kind of stimulus. The hypothalamic control, it can be either direct or indirect. If it's indirect, it will be through the reticular system. We know that inside the hypothalamus, we will have centers for the heart activity, for the blood pressure, for the body temperature. How would it correct all these things? Via activation of either the sympathetic or the parasympathetic system. The hypothalamus also have centers for emotional stages and biological drives, and reactions for what we call fight or flight system. The very final part here is the developmental aspects of the autonomic nervous system. Now, of course, autonomic nervous system in young age hardly happens, and if it does, it's because of injury. You can injure the sympathetic chain in young individuals because of surgery or stab wound or a bullet wound, and that of course will impair, for example, the sympathetic stimulation to the organs they will be supplied, like Horner syndrome, for example. That happens because of injuries in the cervical region of your sympathetic ganglia. It was very common when tuberculosis was common, because tuberculosis often have a caseating lesion nearby. In old age, autonomic nervous system efficiency declines, and that of course leads to lots of problems. You can see constipation, because the autonomic nervous system is not working very well, the emptying of the bladder, the emptying of the intestine, the secretion of the eye, then you get dry eyes and you get frequent infection, and we get a situation called orthostatic hypotension. That is when your blood vessels are late in responding, or your body is late in responding to the blood vessels being filled with blood, what happens is, if you have been sitting, and most of us have encountered that one way or the other, when we have been sitting for a very long time and then you stand up suddenly and the blood now rushes to the lower limb blood vessels and not returning fast enough to the brain, causing a transient hypotension and transient ischemia to the brain, and some of us can collapse because of this. And we also know that people who have been standing for too long in parades, they can also suffer from collapse because all the blood now will go to those lower limb blood vessels and it would not reach the brain.